Hey everyone, getting ready for that big surgical tech exam on wound management and general surgery? Well, you've come to the right place. Think of this as your crash course, your high-speed review of the stuff you absolutely, positively have to know.
All right, no time to waste. Let's jump right into a scenario. Picture this, because, in a real OR, every single second is precious. This isn't just some random question on a test, right? This is the kind of call that can literally change everything for a patient.
So here's how we're going to tackle this. To really make these ideas stick, we're going to follow one patient's story from start to finish. We'll talk about getting access, figuring out the pathology, grabbing the right instruments and sutures, and then, finally, the techniques to close the case. Simple as that.
Okay, so section 1. It all starts with that first cut. For our trauma patient, two things matter more than anything else: speed and exposure. You got to get in, you got to see everything, and you've got to fix the problem like yesterday.
And bam, there's your answer to that first question, the midline incision. You've got to know this one. It's the absolute workhorse, the go-to for emergency laparotomies. Why? Because it's the fastest way in, plain and simple. It's a straight shot into the peritoneal cavity. And if the surgeon needs more space, they can extend it up or down in a heartbeat.
Now this is so important to get. The incision isn't random. It's all about the goal. You see? For trauma, you need speed, so you go midline. Need to get to the gallbladder? A subcostal gives you the perfect window. And for a GYN procedure where looks matter, you've got the Pannenstiel. Every single cut has a purpose.
All right, we're in. The surgeon's taking a look around, and there it is. We found the problem. Imagine seeing a piece of the intestine, but it's twisted, like dangerously twisted up on itself.
That right there, that's a volvulus. This is a classic high-yield term for your exam, so lock it in. That twist isn't just a knot. It's choking off the blood supply and creating a total roadblock. If you don't fix it, and I mean right now, that tissue starts to die.
Now, here's a super common trip-up on exams. Do not get volvulus mixed up with its evil twin, intussusception. They both cause a blockage, but they get there in totally different ways. A volvulus is a twist, and intussusception is when the bowel telescopes into itself. Think twisting versus folding. You gotta know the difference.
So this whole idea of blood supply getting cut off, it's a huge theme in surgery. You see it with volvulus, and you definitely see it with hernias. Look, an incarcerated hernia is bad news, right? The tissue is trapped. But a strangled hernia, whoa, there's a full-blown 5-alarm emergency. That means the blood flow is gone, the tissue is dying. We are officially in a race against time.
Okay, so the surgeons found the volvulus. They know what they need to do. Now, it's your time to shine. As the tech, this is where you become a mind reader. You have to anticipate. You got to have the right instrument in their hand before they even finish saying its name.
Pay attention here, because this table is pure gold for your exam. Back to our patient with the volvulus. That bowel tissue is super delicate, right? You can't just grab it with anything. That's where the Babcock comes in. And trust me, when you can slap a Babcock into the surgeon's hand right when they need it, without them saying a word, that's what makes you a rock star tech. You need to know these.
And hey, let's not forget the needle. It's just as crucial as the clamp. When you're stitching up something delicate like the bowel, you would never use a cutting needle. Think about it. You want a taper needle. It's like the difference between pushing a nail into wood versus stabbing it with a knife. The taper needle gently separates the tissue fibers instead of shredding them. You get less damage and a way better leak-proof seal.
Okay, good news. The volvulus is untwisted. The bowel is pink and happy again. We saved it. Awesome. But we're not done yet. Now comes the art of putting everything back together. And this is where your suture knowledge is going to be put to the test.
First things first, you've got this big question. Absorbable or non-absorbable? Does it dissolve or does it stay forever? And it's really just common sense. For tissues deep inside that heal up pretty fast, like the lining of the bowel, you want something absorbable that'll just disappear over time. But for that super tough fascial layer, the stuff that holds your guts in, you need something permanent, something non-absorbable that's going to provide support for the long haul.
All right, next choice, monofilament or multifilament. Basically, is it one solid string or a bunch of strings braided together? A monofilament is just like fishing line. It's smooth, it's a single strand. A multifilament or braided suture is like a tiny little rope. And that monofilament is amazing because it glides through tissue with less friction and, this is huge, it gives bacteria literally no place to hide.
So, let's put it to the test. Why would you pick a monofilament for a potentially dirty wound? What do you think?
It's all about infection, right? That braided suture, that little rope has all these tiny gaps and crevices, perfect little hiding spots for bacteria. The smooth monofilament has none of that. In a contaminated wound, that's a game changer.
Okay, write these 3 down. This is like the holy trinity of suture properties. You've got tensile strength, that's how strong it is. You've got memory, that's its tendency to want to curl back up. And you've got capillarity, that's its ability to wick up fluid like a straw. These 3 things tell you everything about how a suture is going to act, both in your hands and inside the patient. You have to know these for your exam, no question.
All right, we're in the home stretch now. Let's talk about closing the case. We've fixed the volvulus, we've picked our sutures. Now we just have to put it all back together and make sure it stays that way.
So, what's the technique going to be? Well, for that deep fascia layer, the surgeon's probably going to use a continuous stitch, one long running stitch. It's quick and it spreads the tension out evenly. But then when they get to the skin, they might switch it up and go with interrupted stitches, individual little knots. It takes more time for sure, but it's way more secure. Think about it. If one of those knots pops, the rest of them are still holding strong.
And one last thing before we wrap up. Let's talk about what happens after the closing stitch. Sometimes you need a drain. And if you're talking about the bile duct, you have to know about the T-tube. It's a classic. This little T-shaped tube gets placed in the duct to let bile drain out of the body while everything heals up inside. It's a safety valve, preventing a nasty backup of bile. Super important for a safe recovery.
So let's bring it all home. After everything we've talked about, from that first midline incision to the very last skin stitch, what's the one big idea that ties it all together? It's this: do as little harm as possible while keeping the patient as safe as possible. Minimize that tissue trauma, maximize patient safety. Every single choice, the tool, the needle, the suture, the knot, it all comes back to that one core principle. If you can remember that, you're not just going to pass your exam, you're going to be a fantastic surgical tech. Now go out there and ace it. Good luck.